Okay. Hello, everyone. A very good afternoon to all of you. And on behalf of the College of Physicians Malaysia, I, Dr. Norisha, would like to welcome all of you to today's webinar. And today will be our final session for our month of cardiology. And the topic which we are discussing on today is actually a very important and relevant one, which is what's new in atrial fibrillation. And to enlighten us on this day, we have with us our speaker, who is a consultant cardiologist and electrophysiologist at Hospital Raja Permaisuri Banun Ipoh. Our chairperson for today would be Dr. Ma, and we will be waiting for Dr. Ma in a while, but we will start with the webinar session first. Over to you, Dr. Hazlina.
Thank you very much, Dr. Norisha. Assalamualaikum and very good afternoon. This is the topic of my presentation today, what's new in atrial fibrillation. I have nothing to disclose. Okay. Atrial fibrillation is the commonest arrhythmia that we encounter in our medical setting. And actually, atrial fibrillation is a very old disease that had been encountered nearly 300 years ago. And the first documented AF by ECG was done in 1909 by Dr. Thomas Lewis. And it is expected that the prevalence of the AF worldwide will be increased in the future. This is mainly because of the two reasons. Number one, our world has been populated with aging population. And number two, more and more people now survive from chronic illnesses due to advancement in medication and also in surgical procedure. By 2050 in US, it is estimated that 6 to 60 million people will be living with AF. In Europe, by 2060, it is expected that they have 40 million people in Europe living with atrial fibrillation. And in Asia, which is the most populated continent in the world, it is estimated by 2050 we have 72 million individuals with atrial fibrillation in Asia. Of note, all this estimation was done before the COVID-19 pandemic. As we know, during this pandemic, more than 5 million people worldwide have been died directly because of the illness, and million more die due to post-COVID complications. Therefore, I expected that this estimation will be differ from this published paper. How about Malaysia? In Malaysia, unfortunately, until now, we don't have a registry for atrial fibrillation. But in year 2007 to 2014, Dr. Lim and her colleague from UiTM did this study, and they found out that the prevalence of atrial fibrillation in Malaysia during that time was low at 0.54%. However, when I and my colleague from Hospital Sultanah Bahiyah Al-Usta did another study in 2018, we noted that the prevalence of AF detected by smartphone single-lead ECG device among elderly 65 years old and above was actually high at 6.9%. As you can see here, there are many risk factors that associated with AF, but as you can see here, only 4 is non-modifiable risk factor. The other risk factor is modifiable, and certain illnesses that are related to atrial fibrillation can be treated. This slide shows the AF-related outcomes. There are 7 important AF-related outcomes. Number 1 is death, stroke, LV dysfunction and heart failure, cognitive decline and vascular dementia, depression. Depression occurs in 16 to 20% patient with atrial fibrillation. Impact quality of life, which is in the majority of patients with AF occur in more than 60% of patients, and also hospitalization because of atrial fibrillation. Therefore, in management of AF, number one, it is very important to screen and to confirm the diagnosis of AF, and then to improve the quality of life of the patient. We need to start patient on certain medication or doing certain procedure to control the rate or control the rhythm. Number three, to reduce the morbidity and mortality, we need to start anticoagulation in patient who is eligible, in patient who is indicated for anticoagulation in order to prevent risk of stroke and also risk of systemic thromboembolization. And last but not least, on the same time, we also need to treat illnesses that are associated with atrial fibrillation. Screening for AF is still debatable, but in both Canadian and European guidelines, they strongly suggest opportunistic screening for AF in people 65 years old and above at the time of unrelated medical encounter. And European guidelines also suggest systemic screening for patients with higher risk of stroke. This is based on their stroke study. But American guideline, Canadian guideline, so far they did not recommend systemic screening for patients with higher risk of stroke. There are many devices besides pulse taking and 12 lead ECG for us to screen patients with AF. Nowadays, we can screen AF by doing automatic blood pressure monitoring. We also can do single lead ECG by using the specific device. We also can screen by using smartphone apps or smartwatch. In hospital setting, we can, in patient that we highly suspected to have AF, we can do a longer duration of Holter or assign patient for ECG patches, or in certain patient which is we think very likely to have AF, but we cannot capture in Holter or in ECG patches. So another method that we can do is to implant the implantable loop recorder. So this is an example of device to record the single lead of ECG. This is called Cardiomobile. So what we need to do here is first, of course, we need to buy the device, and number two, we need to download the cardiac apps into our smartphone, and then we just put 2 fingers at the device pad and wait for 30 seconds so that the ECG can be recorded. This is keyword from management of AF in 2020 ESC guideline, from CC to ABC. So the first C is we need to confirm the atrial fibrillation. So the confirmation can be done by 12-lead ECG or by rhythm strip showing AF pattern ECG for the duration of 30 seconds or more. After confirmation of atrial fibrillation, the next step, which is very important, is to characterize the AF by apply the 4S scheme. So the first S is to calculate the stroke risk by using the Chartwell score. And the second S is to assess the symptom severity by using the EHRA symptom score. So this is the EHRA symptom score that I'm talking about. So in this scale, the symptom of the patient can be divided into 4 categories: none, mild, moderate, severe, and disabling. Okay, the third S is to assess the severity of AF burden. So these are including the duration of AF, whether the AF can be spontaneously terminated or require DC cardioversion or require pharmacological cardioversion. And last but not least, to assess the subthreat severity. These are including the comorbidities, and also we also need imaging. The basic imaging is by doing the echocardiogram, because we want to know the LA size and also the LA volume index. Okay. After confirm the diagnosis of AF and characterize the AF, the next step is to treat the AF by apply the ABC pathway. So A stands for anticoagulation in order to prevent risk of stroke and also thromboembolism. So in here we apply the Chartwa score. So for ladies, if they have 3 or more score in Chartwas, they are indicated for anticoagulant. For male, if they have score 2 and above, they are indicated for anticoagulation. And B stands for better symptom control, either by giving them rate or rhythm control. And C, to treat the comorbidities and also cardiovascular risk factor. So in my presentation today, I will talk more in the B, better symptom control by rate or rhythm control. This is a classification of AF based on 2020 ESC guideline. So based on the duration of AF pattern can be divided into first diagnosed AF. First diagnosed AF defined as AF not diagnosed before, irrespective of its duration or the presence or severity of AF-related symptoms. For example, you encounter patient that's never been diagnosed with AF in the ED, presented with fast AF. So irrespective of the duration of the AF before it terminated, and also whether the patient presented with heart failure or not, if it is the first presentation of AF, then that's what we call first diagnosed AF. And then we have paroxysmal AF. So it is defined as AF that terminates spontaneously or with intervention within 7 days of onset. Then we have persistent AF, AF that is continuously sustained beyond 7 days, including episodes that are terminated by cardioversion after 7 days or more. Then we have long-standing persistent AF, which is continuous AF of more than 12 months duration when decided to adopt a rhythm control strategy. And permanent AF, AF that is accepted by the patient and the physician, and no more further attempts to restore or maintain the sinus rhythm will be undertaken. So here you can see that permanent AF is rather a therapeutic attitude of the patient and physician rather than pathophysiological attribute of AF. So at any time, if this group of patients reconsider for rhythm control, then the permanent AF becoming long-standing persistent AF. So for rate control therapy, we have multiple methods to control the rate, either by giving medication, either apply paste and poison. Paste and poison mean we implanted the pacemaker and control the ventricular rate by giving medication, or we apply paste and poison plus AV node ablation. So this is outline of rate control therapy. So the rate control therapy basically actually is the background therapy in all AF patients, and it can be the first choice therapy in patients with no or minor symptom of AF. And thirdly, it can be therapy after failure of rhythm control, and also therapy when risk restoring rhythm to sinus rhythm outweigh the benefits. So if we opted for rate control therapy, it is advised for us to aim for linear rate control, means heart rate 110 beats per minute or lower. So this is based on very old study called RACE study. So in this study, they said that in permanent AF, linear rate control, which is resting heart rate less than 110, is as effective as strict rate control, resting heart rate less than 80 beats per minute in preventing cardiovascular morbidity, mortality. And then if we have a patient with AF and also heart failure, in one study called Certified study, they said that long-term survival after CRT among patients with heart failure with AF and AV node ablation is similar to that observed among patients with heart failure in sinus rhythm. And if we try to control, if we opted rate control by giving drug, then the outcome in terms of mortality will be higher. So in heart failure with AF, we need to consider to put them on CRT and do AV nodal ablation to achieve more than 88% of biventricular pacing. So for drug to ventricular rate, the first choice in patient with LV ejection fraction 40% or more is either beta blocker, deltasem, or verapamil. However, if the patient has concomitant ischemic heart disease, it is advisable to use beta blocker rather than calcium channel blocker. And in patient with ejection fraction less than 40%, the first choice is beta blocker, either we combine with digoxin or not. Then we go to rhythm control therapy. So for rhythm control therapy, we also have multiple methods to control the rhythm. Number one, by giving anti-arrhythmic drugs. Number two, by doing catheter ablation. And number three, surgery. These are factors favoring rhythm control rather than rate control. These are including young patient with paroxysmal AF, new onset AF, patient with tachycardia-induced cardiomyopathy, patient with no or few comorbidities of heart disease, and patient with failure of rate control. I think this study was published in 2020, early rhythm control therapy in patients with atrial fibrillation. So in this study, they want to assess if early rhythm control therapy can reduce cardiovascular risk in patients who had recent atrial fibrillation. Recent atrial fibrillation here means the atrial fibrillation was diagnosed 1 year or lesser before the enrollment. So this patient involved more than 2,700 patients. So they are divided into early rhythm control and usual care. The usual care is by giving the rate control medication. So as you can see here, in the primary outcome, CV death, stroke, hospitalization with heart failure or SCS is lower in patient with early rhythm control compared to patient with usual care. But the night span in the hospital is about the same in both groups. And secondary outcome, which is serious adverse event related to rhythm control therapy, unfortunately, more patients in early rhythm control develop serious adverse event compared to patient with usual care. So if we look at this study in detail, we can see that those who are assigned for rhythm control in this study, in the majority, received the anti-arrhythmic drug. Only 8% received catheter ablation. So here rise the question, whether if we upfront the catheter ablation since the beginning, whether the outcome of the study will be differ from what we get here. There is some common anti-arrhythmic drug that can be used for restoration of sinus rhythm. So in most hospital in KKM, I think the drug that available either flecainide or amiodarone. So as you can see here, in my hospital, we only have oral flecainide. So initial dose for cardioversion is in between 200 to 200 milligram, and acute success rate is at 51% at 3 hours, and it increased to 72% at 8 hours. If we want to use flecainide, we need to be careful because this flecainide and any class anti-arrhythmic class 1C, we cannot use it in patient with ischemic heart disease or in patient with significant structural heart disease. And be aware that this drug also can induce hypotension. And flecainide also can induce very fast atrial flutter with one-to-one conduction. This is because the action of the flecainide in the atrial tissue is more towards slowing the conduction rather than prolong the refractory period. Therefore, if you have AF, the fibrillation wave will become organized and then leads to the atrial flutter. Therefore, if the patient have a concomitant history of atrial flutter, it is not advisable to use flecainide. And it is also recommended to load patient with AV nodal blocking agents such as beta blocker or short-acting calcium channel blocker before we start patient on flecainide. The other common drug that's used in KKM hospital is the amiodarone. So amiodarone, we have IV and tablet. So for acute restoration of sinus rhythm, we use IV, and the initial dose for cardioversion is in between 5 to 7 milligrams per kg over 1 to 2 hours. And acute success rate is about 40% in 8 to 12 hours to several days. So if you use amiodarone, you also need to pay particular attention for the risk of thrombophlebitis. And amiodarone also can cause hypotension and bradycardia, and also can cause AV nodal block, and also can prolong the QT interval. Okay, the faster drug to convert from atrial fibrillation to sinus rhythm is either varenicline or ibutilide. So both drugs are not available in most of the KKM hospital. Varenicline, I think it is the selective atrial antiarrhythmic drug. So the initial dose for cardioversion is 3 milligram per kg over 10 minutes, and acute success rate can be observed less than 1 hour and 50% conversion within 10 minutes. And for the ibutilide, the initial dose for cardioversion is 1 milligram over 10 minutes, and acute success rate in AF can be seen in 31 to 51%, and in atrial flutter in between 63 to 73% within 1 hour. Now we are moving to catheter ablation of symptomatic AF. So in this 2020 ASC guideline, class 1 recommendation for first line catheter ablation is whenever patient fail drug therapy, or in patient with paroxysmal or persistent AF, they are symptomatic. On the same time, they also have heart failure with reduced ejection fraction. So the recommendation here is class 1. So this is based on this study, Castle AF trial. So in this study, they found out that there is significant lower rate of composite endpoint of death from any cause and hospitalization for worsening heart failure if we do catheter ablation rather than using antiarrhythmic drug. So the result of this trial is contradict with another trial called Cabana trial. So in this Cabana trial, also the same, they compare catheter ablation versus antiarrhythmic drug therapy, and they found out that catheter ablation was not associated with an improvement in clinical outcomes. The clinical outcome that they want to observe in this study is mortality, stroke, bleeding, and cardiac arrest. However, catheter ablation resulted in durable improvement in quality of life, reduction in atrial arrhythmia recurrence, and also reduce the AF burden during a follow-up of 5 years. So even though this Cabana trial, the primary outcome is negative, but then the secondary outcome give a clue or give idea for researcher to do more study regarding catheter ablation and improvement in quality of life. So why the result in Castle AF and Cabana trial differ? This is because the setting of the trial also greatly differ. So in Castle AF, the inclusion criteria is symptomatic paroxysmal or persistent AF with ejection fraction 35% or below, and NYHA class 2 or more, and all patients had been implanted ICD or CRTD. So in Castle AF trial, 100% of patients have congestive heart failure. So if we compare with Cabana trial, the inclusion criteria is new onset or undertreated paroxysmal or persistent AF, and only 15% patients in Cabana trial have congestive heart failure. So as you can see here, if patient has AF and heart failure, if you do catheter uh, catheter ablation, it will improve the morbidity and mortality of the patient. So, catheter ablation for AF. So in 1998, Dr. Hellinger and his colleague demonstrated that AF trigger was within the pulmonary vein. So pulmonary vein isolation remains the cornerstone technique in AF ablation. So far, we have two types of catheter AF ablation. The first type, at the bottom, is by using heat. So this is what we call point-to-point radio frequency ablation, assisted by 3D electroanatomical mapping system. The above picture is another method of catheter AF ablation. So in this method, we use freezer. So this is what we call cryoballoon AF ablation. So there are many studies have been done to compare the effectiveness of cryoablation compared to radiofrequency ablation. So some of the randomized control trial are freeze AF, fire and ice, and Circa dose. So as you can see here, in all these three studies, cryoballoon ablation was non-inferior to radiofrequency ablation. However, overall complication rate, we found out more in cryoballoon ablation compared to radiofrequency ablation. And in all three studies, none of patients in radiofrequency ablation developed phrenic nerve injury. But in cryoballoon ablation, there is a risk for the patient to get phrenic nerve injury. This is a natural history of atrial fibrillation. At the time patient first diagnosed to have paroxysmal AF, the trigger of the AF mainly located at the pulmonary vein. So it is called pulmonary vein dependent AF. However, when the duration of the AF progress, then the trigger becomes substrate, and now it is called substrate dependent AF. So as you can see here, in substrate dependent AF, there is LA enlargement and also associated with LV dysfunction and also LV enlargement. And then if the duration of AF longer, it becomes more and more difficult for us to convert the atrial fibrillation into sinus rhythm. So from here, now people will question whether if we do early catheter ablation, whether the outcome of the AF better or not. So these are few trials that have been done to assess early catheter ablation for atrial fibrillation. As you can see here, if we do early catheter ablation, then we observe the AF recurrent rate will be lower if we use radio frequency ablation as method of the rhythm control compared to anti-arrhythmic drug. But as we know in the previous study in Cabana trial, there is no improvement in mortality or morbidity. But in terms of quality of life, in terms of symptom, there is improvement. So that's why they did all these three trials to see whether early catheter ablation will improve the symptom and the quality of life and also the AF recurrence. So far, there are three randomized studies demonstrated that cryoablation is superior to anti-arrhythmic drug therapy for prevention of atrial arrhythmia recurrent over 12 months. So they are stop AF first, cryo first, and early AF. Early AF and stop AF, basically the objective is the same, but the setting of the study is different. Early AF is done in Canada, stop AF was done in US. So in both study, the question that they want to answer in the study is whether first-line ablation by using cryoballoon ablation effective than anti-arrhythmic drug in preventing recurrence of atrial tachyarrhythmia. So, as you can see here in early AF, the risk of recurrence within 12 months after cryoballoon ablation is lower compared to those in anti-arrhythmic drug. The same thing also observed in stop AF ablation. The risk of recurrence within 12 months is lower than anti-arrhythmic drug. And because of the positive result in stop AF trial, now I think cryoablation have been received FDA approval to be used as initial therapy in patient with recurrent symptom of atrial fibrillation. In one study done by doctor in Australia, there are another condition that we also can consider for first-line catheter ablation. So these conditions are including tachybrady syndrome. In the past, patients with tachybrady syndrome, they always receive dual chamber pacemaker plus rate control medication to control the ventricular rate. But in their case series, they found out that in tachybrady syndrome, the pause after termination of the tachycardia can be treated with catheter AF ablation. When we ablate the AF, then the sinus node recovery time will be improved. So in tachybrady syndrome, the sinus node disease is reversible rather than irreversible. And then they also said that in certain professions, such as in pilot, military service personnel, or athletes, whenever we think that medical therapy can impair their work performance, we also can discuss with them for catheter AF ablation. And catheter ablation can be considered in patients with psychological distress. In one study done in 2018, they found out that severe psychological distress was present in 35% of patients referred to a tertiary center for atrial fibrillation management, and 20% reporting suicidal ideation. So in this group of patients, we also can consider catheter AF ablation after discuss with the patient. Okay, regardless what method we use to treat the AF, either rate control, rhythm control by using anti-arrhythmic drug, rhythm control by catheter AF ablation, we need to bear in mind that we also need to treat the risk factor for AF. If we don't treat the risk factor for AF, then the risk of AF recurrence will be high. So these are important risk factors that we need to treat concomitantly. Number one is hypertension. We need to make sure that the blood pressure is within the therapeutic value, and advise the patient to be active. And then for patient with OSA, we need to refer them for sleep study to confirm the diagnosis, and patient with confirmed to have OSA, we refer for we refer for CPAP. And then we need to advise our patient to cut down the alcohol, and also to have good control of lipid, stop smoking. And for obese patients, we advise them to reduce the weight and achieve the target BMI, which is more than 27 kilogram per meter squared, and also to control the blood sugar. Okay, the latest therapy in AF is hybrid AF therapy. This one had been done in US and UK, but not yet in Malaysia. So the idea of hybrid AF therapy is to overcome the low successful rate of catheter ablation in long-standing persistent AF. Because in long-standing persistent AF, the trigger of the AF is beyond the pulmonary veins. And the other common site of a trigger for AF are at the posterior wall of LA, because embryologically, the posterior wall actually is a part of the pulmonary vein, and the next structure is the LA appendage. So hybrid AF therapy actually is a combination of endocardial plus epicardial ablation of AF. So what they did in this hybrid AF ablation is involve electrophysiologist and also the cardiac surgeon. So the electrophysiologist will go in to do catheter ablation by oscillation the pulmonary vein from the endocardium, and then the surgeon will go in by making a small incision below the sternum, and then put the thoracoscopy, and then they insert the ablation catheter and ablate the posterior wall of the LA. So this posterior wall of the LA usually is a difficult part to reach from endocardial ablation. So if this is the picture of surgical plus catheter ablation of AF. So in the very first picture is the picture of LA and posterior wall of the LA and pulmonary veins before the surgical and endocardial catheter ablation. So after surgical ablation, you can see there is no more trigger from the posterior wall of the left atrium. And then after that, we did endocardial ablation. We isolate the pulmonary vein, so no more trigger from the pulmonary vein and posterior wall of the left atrium. So this is the study to see the outcome of a hybrid AF versus endocardial catheter ablation alone for the treatment of patient with long-standing persistent AF. And as you can see here, patient who receive convergent treatment has more freedom from any atrial arrhythmia at 1 year compared to those with endocardial catheter ablation alone. So this is the future of in AF ablation. So in the future, for radio frequency balloon, we will have more types of balloon: stacker hot balloon, heliostar, luminized radio frequency ablation. And for energy, nowadays we only have heat and freezer, but in the future we may get another energy sources such as endoscopic laser ablation, pulse field electroporation. And then in terms of a catheter, there will be multi-electrode ablation catheter. And for lesion visualization, there will be an NADH autofluorescent guided ablation. So in conclusion, I think atrial fibrillation is a unique disease. So it is very important to characterize all patients with atrial fibrillation and decide the best treatment option for them, and always discuss the treatment option with the patient. So the decision for what is the best therapy must be the decision between the patient and also the doctor. And do consider catheter AF ablation in symptomatic young new onset paroxysmal AF patient, in symptomatic AF despite optimal medical therapy, also in AF with heart failure reduced ejection fraction, and also patient in tachy-induced cardiomyopathy, and also consider to do catheter AF ablation in patient with symptomatic tachybrady syndrome. With that, thank you.
Thank you, Dr. Hazlina. Wow, it was very extensive. I'm sure the audience have gained a lot of knowledge from this lecture. Now, without further ado, we have a lot of Q&A here. So, Dr. Hazlina, and I must congratulate Dr. Nolin. Dr. Nolin Shuhada, she actually sent in about 70-80% of the question. Thank you, Dr. Nolin. The first question is from Dr. Nolin. She asked, how do we decide which patient to revert to sinus rhythm and when just to rate control?
Okay. Thank you, Dr. Nolin, for your question. So, as you can see in 2020 ESC guideline, they suggest us in management of AF that we characterize our patient. So we assess the severity of the AF, the duration of the AF. So if we encounter the patient with new onset of AF, and they are symptomatic, so it is one of the indication to revert them to sinus rhythm rather than just rate control. And also in young patients with no comorbidity but have AF with reduced ejection fraction, this is another group of patients that we can consider to do to revert the AF into sinus rhythm.
Okay, the way I look at it, to make it very simple, two things only. You are listening, two things to decide whether you want sinus rhythm or just rate control the patient. The first thing is symptom. When I say symptom, it includes the ultimate symptom of heart failure. Sometimes we misunderstand and say, oh, the patient doesn't have palpitation. No, heart failure is the ultimate symptoms of atrial fibrillation. So if the patient has got palpitation or is already developed the ultimate symptoms of heart failure, you need to consider to put the patient in sinus rhythm. First thing, symptom. Second thing, the age. Umur. When I say age, I do not mean the age of patient, the age of the AF, the age of atrial fibrillation in that particular patient. For example, a 30-year-old man, 35-year-old man has been having AF for the past 15 years already. Well, his AF is very old compared to a 70-year-old man had AF since yesterday. His AF is very young, so you should consider putting the patient back in sinus rhythm if the AF is young. Just two things, symptoms and the age of AF. All right, very good. Dr. Nolin again asked, and how is the treatment for ACS with AF? Dr. Hasrina, what do you think?
Okay, ACS with AF, we usually further divided whether the patient have STEMI, non-STEMI, or unstable angina. So in STEMI patient, there is the dilemma. For example, if patient on warfarin, so if they came with ST elevation MI, so if you work in PCI capable patient, so this group of patient you need to refer for chorus PCI rather than thrombolysis. So some experts said that if the warfarin level 1.7 or below, still safe to give thrombolysis. But I think for the 70 or the patient, it's better to do PCI rather than give thrombolysis. And if the patient on NOAC, one of the things that we need to ask is when the last dose they take the NOAC. So if the last dose is more than 12 hours, then some people say it is safe to give thrombolysis. But again, if you work near to PCI capable center, better send patient for primary PCI. And then if patient with non-STEMI and unstable angina, usually at the time they admitted to the hospital because of non-STEMI and STS, we stop the anticoagulant for a while because we need to give anticoagulant either Eristra or Prexane to treat the STS, and then refer the patient as soon as possible to the PCI capable center to do COROS and then KIU PCI.
Okay, thank you, Dr. Haslina. That was very thorough answer to this question. But to be fair to Dr. Haslina, Dr. Nolin, this question require one lecture, like maybe half an hour lecture, because there are so many different iterations of acute coronary syndrome in patient with AF. But I just want to emphasize one thing. To my colleagues who are dealing with acute coronary syndromes and also had the capability to do PCI in the patient, I always tell them this: if you intend to stent the patient, PCI the patient by putting a stent, try to use the stent with the shortest dual antiplatelet therapy duration as possible, because you are going to give patients triple therapy. That will increase the risk of bleeding. So please remember that. If you intend to put a stent in the patient, put the one with the shortest double antiplatelet therapy duration. All right, let's move on. Hi, good afternoon. Is warfarin still the choice of anticoagulant, or could we use newer agents like the dabigatran? Dr. Haslina?
I think if money is not the problem, I think I will choose novel anticoagulant rather than warfarin, because easier for the patient in terms of monitoring, and then also easier for the doctor because we can reduce our load in our clinic.
All right, there's one related question, I think maybe by the same attendee. How to manage an elderly patient like 70, 80 years old with new onset of AF, with underlying diabetes, hypertension, doctor advice risks such as stroke, but not keen to start anticoagulants due to frequent need of coagulation profile monitoring, but can't afford to buy the dabigatran.
Okay, in this question, I think the stroke risk for the patient is already high. So the patient indicated for anticoagulation. So actually, if you refer the patient to government hospital, we have quota for this group of patient to receive, because in elderly, they are fragile and they are high risk to fall. And then if we give warfarin, then if they fall, then they develop intracranial hemorrhage, and then more complication if we give warfarin in elderly patient. So in this group of patient, if you refer to government hospital, we will consider to give patient a novel anticoagulant. And then if the patient is pensioner, we can refer them to Aurelian to get this medication. So there is always a way for them to get novel oral anticoagulant.
I totally agree with Dr. Haslina. Warfarin in this group of patients, even if it's indicated because of a very high risk of thromboembolism, put the patient at very high risk of intracranial bleeding as well. So it's not really the best treatment for this group of patients. Well, if the patient cannot afford it, yes, do refer them to a public center. But that said, because in public center is quota-based, they still may not get it. But then when you refer them to a center, at least they are in the queue to hopefully, one day may get it. That's a very good question. There's one question by Dr. Dolin again. This question a little bit maybe towards more cardiology. For patients on the pacemaker, can single-lead ECG sensor still be used? Dr. Haslina.
Single-lead ECG sensor means
the patient on pacemaker, can they still use the single-lead ECG sensor? I think she's referring to those wearable devices, I guess. I answer on behalf of Dr. Haslina, okay? Can, no problem. Can use. You can use any. You can use cardiac band. You can use the 72 hours or 1 week, 2 weeks, Easy Pro. No problem at all. But the issue is you will see a very small pacing spike if it's in modern pacemaker, because in modern pacemaker is paced bipolar. So sometimes you don't even see the spike. You need to amplify it. So most of the filter system in a single lead wearable system, they are very good. So they actually filter off the pacing spike. You won't even know it. All right, very good. So on to the next, one of my favorite FAQ for many years, also by Dr. Nolin. Thank you. In patients with hyperthyroidism and AF, should we continue anticoagulation even after hyperthyroidism has been treated and in normal range? Dr. Haslina.
Okay, yeah, this is a good question. My answer is yes. Depend on the Chartwell score. If the Chartwell score 3 or more in female and 2 or more in male, they still indicated for anticoagulation. It is because we don't know when the AF will be coming. So at the time the AF came, because patient not 24 hours in rhythm monitoring, so we don't know when it comes, and if we not anticoagulate the patient and patient at high risk to have stroke, then they will stroke up. So my answer that we should continue if indicated based on Chartwell score.
All right. Can I play devil's advocate a bit? So I play the role of Dr. Nolin now. Dr. Nolin asked again, said, but Dr. Haslina, the patient is entirely no other, normal, no medical illness, healthy, young lady, 35 years old, just hyperthyroidism.
Okay.
How then?
I still based on Chartwell score. If the Chartwell score is low and not indicated for anticoagulation, I will discontinue. But if Chartwell score is high, then I will continue. Sure,
I totally agree. The reason why I bring this up is, I'm sure a lot of our colleagues are asking this question. AF with hyperthyroidism, should or should we not anticoagulate? We must have this mindset here that if a patient develop atrial fibrillation with hyperthyroidism, this is a plus syndrome. Why I call it plus syndrome, plus as in a plus sign, tambah. You are not looking at a pure hyperthyroidism patient. Just imagine like this. 2 patients admitted on the same day when you're on call. Both patient hyperthyroidism. Both patients also TSH and T4, T3, right, numbers are very similar. Patient A developed atrial fibrillation. Patient B, no atrial fibrillation. But you compare the other clinical parameters, all about the same. Blood pressure also the same. Heart rate also the same. What is the things that plus here that we cannot detect? That's why I said, in this group of patients, there must be something that we're unable to see clinically because of our ability as clinicians we cannot see beyond what we can see. So there must be something there that pushes the patient to atrial fibrillation. What's my message for you? Yes, I agree with Dr. Haslina. Calculate the Chavez score. Chavez score high, you should treat. Chavez score low or 0 or 1, and then you can choose not to treat. Even Chavez score low or high, I would say at the bare minimum, follow up the patient. I've got a few colleagues actually walk to me and say that, hey, I'm uncomfortable in treating now. So Chavez score is on the borderline, like 1 or 2, but I feel like I don't want to treat. Okay or not? I say okay, but don't discharge the patient because you still need to follow up the patient. So there's something that we cannot see beyond our bare clinical eyes here. All right, very good. Thanks, Dr. Haslina. So moving on to the next question. After reverting the patient back to sinus freedom, does patients still need long-term anticoagulation? Yep.
This is also based depending on the Chavez score. If it is indicated, then anticoagulant should be continued. So if you remember the AFFIRM trial, the trial that had been done 20 years ago to see whether rate control is better than rhythm control. So in this trial, those in rhythm control, they stopped the anticoagulation. That's why I explain why patient in that study, why patient in rhythm control develop more morbidity and mortality. So my answer is after you revert to sinus rhythm, if Chavez score is high and patient indicated for anticoagulation, you need to continue.
Totally agree. Remember, in patients with atrial fibrillation, converting the patient back to sinus rhythm with any methods you can think of, cardioversion, medical cardioversion using amiodarone, or even ablation, AF ablation, they are all not cure for atrial fibrillation because atrial fibrillation is a epiphenomenon, means that there are so many factors that are influencing the development of atrial fibrillation. You do not cure atrial fibrillation. It's akin to you do not cure hypertension, you do not cure diabetes. It's always there. You're just making it in remission if you treat the patient well. So same with atrial fibrillation. If you convert the patient back to sinus rhythm, the patient is in remission, but it will come back to haunt you if you do not manage the risk factors well. Very good. So let's move on. This is another very specialized question for Dr. Haslina. Do we perform Watchman procedure in Malaysia? The answer is yes.
Yes.
We do. But I always say the main hindrance are the cost of the Watchman device itself. I'm not talking about the cost in private per se. I'm talking about the cost, the bare cost of the Watchman device itself. Dr. Haslina, you may want to update us. I lost touch already on the cost. Last time it used to cost like 30,000-40,000. How about the price now?
If I'm not mistaken, yeah, around that.
Around there. I thought the price come down after a while. Okay, no problem.
25 to 30K.
All right. Okay, let's answer a question which this particular colleague has put in the chat box. So it's related to Watchman actually. That's why I want to ask this. Take this on. How long should patient be on antiarrhythmic medication if they are in sinus rhythm, or should they be on anticoagulant? So these are answered already. But this is the question from the same audience. Should we offer warfarin to end-stage renal failure, end-stage renal disease with AF?
Okay, when we come to AF in end-stage renal failure, the decision for anticoagulation, we need to discuss with the patient and relative, because in end-stage renal failure, there is no study to support the usage of warfarin or NOAC. And you have to bear in mind, in patient with end-stage renal failure, the risk of bleeding also high. And usually, if they don't dialyze properly, the urea high, and then they can bleed at any time. So in my practice, if I encounter patient with AF and in end-stage renal failure, I will discuss with the patient and also with the relative before starting any anticoagulant. anticoagulation.
Yeah, Dr. Hasina, would you agree that putting a Watchman device, a left atrial appendage occluder in this group of patients is one of the options?
Yes, one of the options, but then we also need to see the prognosis of the patient with end-stage renal failure. Sometimes when they refer to us, the patient is already very, very ill, and then I don't think that it is very beneficial if we put Watchman device.
All right, good. From Dr. Noor Sabarullah. Thanks. Very lengthy question. Allow me to summarize. Patient presented ill in sepsis. The doctor feels that AF is due to sepsis, resolved with treatment, I guess antibiotics, IV antibiotics, or whatnot. Do you regard this as significant and anticoagulate? If Chavez score appropriate, would you subject him for further investigation first, like echo Holter, before starting an anticoagulation?
My opinion, I think patients who develop AF during sepsis, they might have a trigger of AF. So if the sepsis already subsided, the blood parameter already normalized, if you calculate the Chavez score is high, you still need to anticoagulate the patient because they still have risk for stroke and thromboembolic syndrome.
All right, it's the same theme. We are singing the same song now. It's like hyperthyroidism with AF, sepsis with AF. Guys, just think about it. Why we are managing a lot of sepsis patients throughout in our practice? Why certain patients develop AF, certain don't? So it's not a single point A to point B sort of causation thing. It's a lot of things we cannot see in our clinical bare eyes. For example, Dr. Hasina mentioned about the substrates of AF. By saying substrates, right, it's like conveniently I used to say the ingredients to cook AF. Ingredients are already there. That's why you add soya sauce there. Here you have a dish called AF. But in certain patients, we don't have the ingredient. No matter how much soya sauce you sprinkle on the patient, you cannot have the dish. So the bare minimum, if you don't want to treat, follow up the patient. And at the back of your mind, you know the patient is going to redevelop AF one day. Okay, great. This is also one of my favorite scenario. I have a clinical scenario here, say one of the audience. This elderly lady has AF with multiple episodes of ischemic stroke. Previously, also has history of fall with subdural hemorrhage. Ooh. Due to recurrent fall risk, is it worthwhile to withhold the anticoagulant as the risk may outweigh the benefit? Thank you.
So this is another indication for LAA occluder.
Yes, and you know what I'm going to add? Definitely LAA occluder is one of the options here. The other option is, if let's say already that particular patient already suffered from multiple strokes and with obviously risk of bleeding there, they got to assess the patient functional status. Recently, I had the pleasure of giving another webinar on talking about pressing issues on anticoagulation. You know, the final pressing issue I tell my audience is what? You look at the patient, if you really think that the patient functional status already been diminished to an extent that you no longer can revitalize the functional status, so-called, considering no treatment is a treatment, guys. Not albeit the Chavez score in the case that I presented earlier in my webinar, the Chavez score was 9. Is the highest. But I tell my audience that I choose not to treat after discussing with family because that particular patient has got very minimal functional status left. Bedridden, bed sore, contractures of all 4 limbs, basically unable to recognize anyone or so. So not treating the stroke risk based on this profile, I think is fair enough. So sometimes we forget because as doctors, we always say that we want to treat. But no treatment in our practice is maybe one of the treatment. So I would say, depending on how much of functional class remaining at that patient, if there's still a lot, they're relatively okay, still can mobilized, then putting an LA occluder is a choice. And coming back to your point, Dr. Hasina, if let's say the patient already had a very minimal functional class for us to save, then no treatment is an option. Is an option. Yeah. All right, good. What is your strategy plan for CKD stage 3 to 4 with AF compared to end-stage renal failure patient? Wow, this get a bit of granular now already. People asking stage 3 to 4, about to go to end stage but not yet, belum lagi. So how we treat, Dr. Haslina?
I think the question is about anticoagulation, is it?
Yeah. I guess so. Yeah, it's missing there. So I think.
So, in the study of NOAC, they show that if we give warfarin to patient with CKD, so the warfarin will further reduce the eGFR of the patient. So in this group of patients, if the patient indicated for NOAC, so the best, if the patient indicated for anticoagulation, the best is to use NOAC. But I think we need to adjust the dose. We cannot give the usual dose to, but we need to reduce the dose.
Yes, I agree. Unless the patient already been dialyzed, then the nephrologist is of opinion that there's no longer any meaningful remaining renal function, then we can, choose to give warfarin with the mindset that the bleeding risk is still be high in this group of patients. If the patient is not been dialyzed yet, be mindful that warfarin actually accelerate the decline of any remaining renal function. So you need to be mindful about that. So you are, in other words, you are pushing the patient to end stage earlier. So if you use warfarin, I use a lot of novel anticoagulants, not novel anyway, direct anticoagulants in my renal failure patients, not really end stage 1, but stage 2, 3. So they are doing pretty well. I haven't seen them coming back with bleeding. So it's actually the bleeding risk of newer anticoagulants. They're way better than warfarin. Let's put it this way. All right. Final question. Yes. Do we still consider CHADRS score in considering anticoagulant for patients with paroxysmal AF induced by sepsis or other reversible precipitating factors like electrolyte imbalance? So I think it's almost the same theme. Dr. Haslina, you have anything to add?
Yeah, I think we still consider the CHADRS score.
All right. And the last question is, thank you. There's very good discussion. I think we answered almost like more than 10 questions by the audience. Thank you so much. I'm sure you all have brought back loads of knowledge from Dr. Haslina. Let's join me.
For moderating.
Again, sorry? All right, thank you. Although it's virtual, but I still want to invite my audience to joining me in giving Dr. Haslina a round of applause. Yeah. You cannot imagine the applause now. Thank you so much. I'll pass the floor back to our organizer, Dr. Norisha.
Okay, all right. Thank you very much, Dr. Haslina.